So this is the April 2020 MEC Minute, and for the third month in a row, we're going to talk about COVID-19. As much as I like to talk about a different topic, I feel like I have to talk about this again. So why do I feel that way? Well, this is still a dynamic, ever-changing pandemic. We have seen it go from a little bit of background noise back in January to where now it pretty much dominates all of our conversations and all of our actions. Things continue to evolve. Things are different now than when I recorded the March MEC Minute. So a lot of our basic tenets have not changed, but there have become a lot of other changes that have happened with time. When we first started dealing with COVID, testing was not very available, and there were significant delays in turnaround time, but definitely now testing is more available. It is available more quickly, and we're starting to hear more and more conversations about testing for antibodies to the virus and what that may mean to us as EMS providers or as just a member of the general population who's trying to cope with this disease. Treatment recommendations continue to evolve and change. I will talk some later in this presentation about treatment and things that are on the horizon. Most of what we're doing in terms of treatment that involve interventions, procedures, and drugs are things that are being done on a trial basis or are being done because we think it may work. There is still rapidly evolving data on how we might treat this disease. So I think we should talk about that. I also want to talk a little bit about some misperceptions about our non-transport policy. I'll get to that in a few minutes. I also want to briefly review how the public media seems to be influencing how we treat and assess our patients. And that is something that we need to consider, because what we hear in the media, it really doesn't determine how we evaluate and manage our patients when responding to a call. So we'll talk more about that. And then toward the end, I also want to talk a little bit about how healthcare is morphing, particularly in terms of how EMS may morph, because I think what's happening now is going to be ever-changing to our practice and how we respond to emergencies in the future. So just to cover some issues of concern and clarification, I want to be clear. We do have a non-transport protocol or algorithm. We have it available, but it is not in place. It's not in effect. It's in our back pocket. We've developed it with other medical directors in Franklin County so that if we become overwhelmed with EMS volumes, or if the systems of care in Central Ohio become overwhelmed, we could evaluate patients, implement the program, and leave patients with minimal symptoms at home. But it is not in effect at this time. Yes, we have a couple fire departments, such as Monroe Township and the City of Westerville, have elected to implement it, but no one else has. I plan on sticking with my agreement with Dr. Lowe from Columbus, as well as the other medical directors, that we will not implement this protocol unless we get busy and all of the medical directors agree that it's time for implementation. But it's available if we need it. Another thing I think I want to talk about is the purpose of the standoff assessment. So for me, the standoff assessment, where you have minimal patient contact and you have an idea of what is going on, that's our EMS version of scene size up. Do you need to allocate all the resources, all the manpower on your truck to care for this patient, or can one provider do it? So this is kind of that assessment to determine what resources are needed. The standoff assessment does not mean we are not going to touch the patient or do an appropriate assessment. So if we have a patient who has symptoms suggestive of COVID-19, or a patient who has been previously diagnosed with this infection, we should do that standoff assessment, but then we need to evaluate the patient. And for me, the things that are important are basic vital signs. Does the patient have a fever? What's their respiratory rate? And more importantly, what's their pulse ox? It's well recognized at this point that patients with COVID-19 could have some respiratory symptoms. They look fairly good. They appear well with no significant respiratory distress. But if you do pulse ox, their pulse ox could be less than 90. So we have to evaluate these patients to make a determination of whether or not it's safe to leave them at home, or whether or not we recommend they go to the hospital versus the patient who just wants to be reassured. So we need to do that. I also need to be concerned about public media and its influence on how we behave and how we manage our patients. I think we all agree that if a patient can recover at home, they should do so. But that does not mean we do not perform an appropriate assessment on the patient. So our protocol requires a patient assessment. I want to see vital signs on all patients unless they absolutely refuse and do not allow you to touch them. So for me, I'm less concerned about do you listen to their chest, but more concerned about basic vital signs and what's the patient's pulse oximetry. If the patient's hypoxic, we should be recommending transport to the hospital for further assessment. Please, consider what you hear on the news. Be selective in what you believe, because some things are just gossip or rumors, but we have to provide an appropriate assessment to the patient, which means we have to check vital signs, we have to talk to the patient, we have to observe their physical appearance. Changes in testing. The preferred test at this time to evaluate for an active infection, meaning the patient is currently suffering the illness and are a source of infection to others, is a swab placed in the nose that goes all the way toward the back of the nose into the nasopharyngeal area. When we first started doing testing, we talked about doing nasopharyngeal or oral swabs. There's no doubt that the nasopharyngeal swab is the better way to do it, and the swab has to go all the way back. You can't just put it in the front part of the nose. It has to go back, and admittedly it is going to cause some patient discomfort. When we first started doing this, the turnaround time was at best 7 to 10 days. Now, depending on where you go, our turnaround time is a day or less. I know within the Mount Carmel system, we were getting results back in an hour or two. So turnaround time is much faster, and that's important to us. Recently, in the past couple of days, there's been an announcement that LabCorp now has a test available for patients so they can self-swab themselves at home, and then they can send the sample in for testing through LabCorp. I believe it still requires a physician order, but that just shows how the process is evolving. There's also been some discussion in the medical community about are all testing techniques the same? Are all sampling techniques versus what types of swabs you use the same? And I think that's all has to shake out. I know that we have to get a good sample from the back of the nose. Some of the testing techniques require a dry swab rather than a swab that's put in a liquid for transport. But those are all things that are out there in terms of are all of these tests of equal sensitivity and specificity. I think you've probably heard about antibody testing. It is out there. There's a lot of literature suggests that all these tests are not created equal. Last I checked, there are over 70 different antibody tests that were being submitted to the FDA for approval. Antibodies are part of the convalescent process. Typically, for most infections or viruses, when you're looking for an antibody response, it takes 7 to 10 days for your body to start producing the antibodies at least at a level that we can detect. The role of the antibody testing is determined whether or not a patient has been previously infected and now has convalesced or has recovered from their infection. The antibody test at this point is not a good test or a suitable test to determine if someone is clinically acutely ill. The literature I've seen is that the antibody test for COVID-19 typically requires the patient to be sick for 11 to 13 days before they start developing a suitable antibody response. But both these tests are going to be important, I think, as we start to go back to work and we start to change our lifestyles in order to go back to work and deal with COVID-19 at the same time. So I think it'll be important for patients or people to know whether or not they have antibodies to the virus, because if they do, then we would consider them protected, unlikely to be a source of infection, and unlikely to be reinfected if they have another exposure. We also need to have quick turnaround times on testing for active infection for patients who are symptomatic, because if they are positive, they should be quarantined. If they're negative, they go about their business. I wouldn't be surprised if in the next 6 months we see home test kits for COVID-19 that are similar to what you might see for a home pregnancy test. You know, you have a little cartridge, you put some spit in it, and it tells you whether or not you've got an active infection. Maybe that's a pie in the sky idea, but it would not surprise me if that's where we are in 6 months. A little bit of an update on treatment. Keep in mind, hypoxia is common in these patients without symptomatic dyspnea. You might notice they may have bumped up their respiratory rate. They may have a increased tidal volume, meaning they may be breathing more deeply, but clinically they don't appear short of breath. But if you put a pulse oximeter on them, they are hypoxic. And I think for physicians in the community, as we're sending people home with a diagnosis of COVID, but for home treatment and recovery, I wouldn't be surprised if we start sending them home with pulse oximeters with the instructions that if it drops below a certain value, it's time to come back. I will talk in a couple slides more about high oxygen and proning the patient. Proning, which is having the patient lying face down, often improves their oxygenation and postpones or eliminates the need for intubation. We also have to keep in mind as we talk about treatment that the accepted or recommended treatment for this illness is still evolving. And based on a question that was asked on Workplace last week, the utility of hyperbaric oxygen is unclear. It seems to be effective, but it takes time, and then the machine has to be cleaned before you put another patient in it. So if we get in a circumstance where we have a lot of patients who are suffering this illness, hyperbaric oxygen therapy may be suitable or helpful for some patients, but because of the logistics involved with using it, it may not be available to help that many patients. We don't have that many chambers in Central Ohio. Additional talks about some of the specifics you may have heard. Chloroquine and hydroxychloroquine, the anti-malarial drugs, which are also used for some arthritic conditions. If you look at the recommendations that have changed, particularly if you look at the recommendations through the American Thoracic Society, these drugs are only recommended for patients with severe pneumonia. They are not currently recommended for patients who have mild pneumonia who are being treated as an outpatient, or patients who are not requiring intubation, do not have evidence of severe respiratory failure. So these drugs are still being investigated, but current recommendations are that their use be restricted. They do have significant side effects. The biggest one that we all worry about is they do have the potential to prolong the QT interval, resulting in arrhythmias or torsades. Remdesivir is an antiviral that's available intravenously. It was originally developed for use with Ebola patients. Studies are underway. It is out there and patients can be enrolled in the studies, but they're really, again, if you look at the American Thoracic Society, there's no current recommendation that it be given unless it's part of an investigational protocol. Steroids, if you remember from last month, I recommended we not use steroids because steroids have been shown to be detrimental in patients with viral pneumonia. Current recommendations have been revised a little bit that they only be used for patients who are in severe ARDS, who are on the ventilator and are acutely and severely ill. Otherwise, steroids are not routinely recommended. You may have seen the talk about the convalescent serum. That's where serum is collected from patients who've recovered from COVID-19, and it is then given to acutely ill patients. There is a study underway in this country looking at that, and it's being coordinated by the Mayo Clinic. I believe several of the hospitals in town are participating in that study. Some initial information out of China suggests that it may improve patient status. To me, it makes sense. You would think it would. I would wonder if we should be using it sooner in the game rather than later in the game. If the patient's severely ill and on a vent and not doing well, that may be they may be past a point of no return. So maybe this treatment may be better if we give it sooner. Again, that's just my uneducated opinion. There has been some information or concern expressed that patients who receive convalescent serum may not develop the full antibody response on their own that you would expect after the infection. So we don't know if that's going to happen or not, but honestly, if the patient is dying and this is a way of saving their life, then maybe we should save their life and worry about inoculating them with a vaccine in the future to help stimulate their own antibody production. Finally, there's been talk about using ECMO for patients with refractory hypoxia. It does seem to work. We will see more of that, I think, used for patients who are severely ill with severe respiratory failure, use it as bridging therapy to get them past their cytokine storm and the ARDS that they may have developed. I want to spend a little bit more time talking about proning the patient. This is where we take the patient and lie them on their belly and leave them that way. Studies show that it does work. And we can do this, and it often can either reduce the patient's need for oxygen or reduce their need for intubation or delay the need for intubation. But essentially, we put the patient on high flow oxygen, or you can do it after they're intubated, and we put them on their stomach and pad them appropriately. It's something that we can do. It's one of the few things, if you look at the current guidelines from the American Thoracic Society, that's almost universally recommended for patients with hypoxia. But just be aware that if you place the patient in the supine position, they may have a temporary worsening of their SaO2 as their body gets used to this new position. So you wonder, well, why does this work? Well, if you look at the images on the right-hand side, the one on the left is labeled supine. That's the patient lying flat on their back. The one on the right is prone, with the patient lying belly down. These are cross-sections of the chest obtained by CAT scan. If you look at the supine image, you see at the back part of the lungs, you see the white there, and that is the inflammation and the fluids that are in the lung. If you look at the lungs, just from a form of anatomy, most of the lungs are at the back part, the back half of the chest, and the front half of the chest is heart and other structures. So if the patient's lying supine and they've got a lot of secretions and inflammatory products in their airways, gravity's going to pull all that garbage toward their back, and it's going to fill up the lungs, a greater portion of the lungs, because most of the lungs are in the back half of the chest, not on the front half. But if you lay the patient on their belly, then the greatest volume of the lungs is up, and all those fluids and secretions that are in the patient's lungs and getting in the way with oxygen exchange, all of those lungs are now up, and all the inflammatory products go down, again by way of gravity. So you actually have a greater portion of the lungs with an adequate air supply, airflow, and adequate perfusion by blood. So you have a much better ability to oxygenate if you're in that position. So this is why proning has become a big thing in terms of how we manage patients with COVID-19. This is a slide, I believe it's out of Italy. This is a gentleman who is intubated. He is proned. If you look and see, he's got pillows under his hips. He's got some pillows under his chest. His pressure points are cushioned. The EKG monitors leads are actually on his back and not on his front, and he's intubated. And they will leave patients in this position for hours and then bring them back the other way. And they see tremendous improvement in their oxygenation, even if they're on the ventilator. So if you have a patient who's hypoxic, who's really short of breath and is not responding well to oxygen therapy, you should consider proning them on the gurney as you're transporting them to the hospital. I now want to talk a little bit about return to work guidelines. These were updated by CDC last week, and these are guidelines for healthcare workers who have been found to be positive for COVID-19 and make a determination of when they go back to work. So this is pretty much similar to what I talked about last month, but CDC is a little more strong in their recommendations. So they offer two strategies. One is a test-based strategy where you test positive, you're a healthcare worker, you test positive, you're feeling better, when can you go back to work? So the test-based strategy is that you're off work until you have no fever and you have no need for Tylenol or acetaminophen or ibuprofen. Your respiratory symptoms have improved, and you've been tested 2 more times. So 2 times after you've recovered, nasopharyngeal swab, and both times you've been negative for the virus, whereas the first time you were positive. So you had a positive, you now feel better. You've had 2 swabs done that have been more than 24 hours apart, and they're both negative. Now you can go back to work. The second option is totally based upon timeline. There's no testing done. So you've had a positive test, you've been diagnosed with COVID-19, you've been off work, when can you go back? So in this basis, or in this pathway, You have to have had 72 hours or more where you've had no fever without a fever-reducing medication, so no Tylenol, no acetaminophen, no ibuprofen, and you've had constant improvement in your symptoms. Plus, it's been at least 7 days since you first developed symptoms. So that is the second option. There is no follow-up testing. The CDC prefers the test-based strategy. I guess if you want to be a purist, that would be a better strategy. I'm really more advocating, though, for the non-test-based strategy because you don't have to do any more follow-up testing. And the reason I'm not wild about follow-up testing is if you're sick, we need you back at work. And if you had a positive test for COVID-19, you may still shed virus through your nose for weeks, even though you're clinically better, and even though that virus is no longer infectious. So studies have shown that people can continue to shed virus even though the virus is no longer infectious for weeks. So if we start down this test-based strategy, it could take you a long time to get back to work, depending on how long it takes to get two tests that are negative more than 24 hours apart. So my recommendation has been to use the non-test basis, simply because I think it's a reasonable process that was more likely to get you back to work quicker. When you do go back to work after that positive test, you should wear a face mask at all times until your symptoms are totally gone or until 14 days have passed, whichever is longer. So if you feel well but you got sick 10 days ago, you still got to wear a mask for another 4 days. Or if it's 14 days since you got sick but you still got a cough, still don't feel 100%, you still got to wear the mask until it's better. During this 14-day period, you also have to be restricted from contact with anybody who may be immunocompromised. And you have to self-monitor for symptoms for any suggestion that you may be having worsening symptoms or recurrence of your symptoms. So you should self-monitor with your temperature checks and so on during that 14-day period. The last thing I want to talk about is the new norm. So 911 EMS is not going to be the same. This is one of those life-changing events for us professionally, whether you're a physician, or whether you're an EMS provider, or whether you work in the dispatch center. So things are going to be different from this point forward. What is the new norm going to be? I'm not sure. I just know it's going to be different. But I've got some ideas. So, what will be like from this point forward? Will our response patterns continue or will they change? So will we continue to send the usual assignment that we send for someone who's short of breath or has minor symptoms? Don't know. I think from this point forward, we're going to continue to stand off a little bit. I think we'll be more at ease using PPE. So, in a year from now, we may still be wearing masks, even for low-risk patients. At some point, we may develop a process where we transfer 911 calls to nurse call lines rather than dispatch a truck. That's in our back pocket now if we get overwhelmed at the 911 call center. So, that's something to consider. Or would some of our calls go on a list? We're not going to send a truck right now. We'll send somebody in the morning. We'll send somebody on a non-emergency basis. It could be a community paramedic. It could be 2 EMS providers in a pickup truck. But we'll send somebody, but it's not going to be an ambulance. We'll take a look at you. I think we need to be prepared for transporting to other treatment locations. Currently, Medicare has suspended the requirement that to get paid, we have to transport the patient to the hospital. Maybe that will continue after the fact because I think they'll find out that it costs less to transport a patient to an office, a physician's office, or to a urgent care center than if we transport them to a hospital where the cost of care is going to be higher. I think we think to figure out what's the role does telehealth play in EMS response and in the 911 call centers. How's that going to change in the future? Might it be that certain calls go to a telehealth provider rather than have a truck dispatched? Or could EMS have a telehealth consult or conference with a provider using the tablet that they have at the patient bedside? And might there be a change in our scope of practice for EMS providers in the future? There are already some things in the work where paramedics will be allowed to do analysis of body fluids with the exception of spinal fluid and amniotic fluid. So maybe we'll be doing more point-of-care testing in the field to make a determination of does the patient need to go to the hospital or as part of a telehealth consult. So a physician or nurse practitioners on the other end of the video call, and we do some blood work at the scene to help make a determination of does the patient get transported or not. Those are all things to think about, and I'm sure you can come up with other ideas of how the new norm is going to evolve and where we're going to be in a year or 2 years. Just some closing comments. These are the same comments I used last time. Every patient encounter for us is a COVID exposure. It's not just a cardiac arrest. It's not just patients with respiratory symptoms. We have had providers exposed who thought they were going on a routine non-COVID call, and it turned out to be a patient who put them at risk for COVID-19. So every patient encounter from this point forward is COVID-19 until proven otherwise. Keep protecting yourself. Use your PPE, wash your hands, do the things you're supposed to do to keep yourself and your family members safe. And then monitor your health and report any symptoms of acute illness. And again, information for you via CDC and ODH. These web pages are changed on a daily basis. I suggest you go there if you have any questions. Again, thank you and be safe.